So today we're going to be talking about LARCs. So LARCs are with Chef Summer, myself. So a bit of a tasting plate on long-acting reversible contraceptives. But yeah, so just some background on me and about why I'm presenting on this today. My background's Doctorate of Medicine. I'm now a Public Health Program Officer at Aqua. Part of my degree was actually completed in Kalgoorlie, where some of you are calling from today. I did some brief placements at Bega and got to do some placements with their O&G team there, which I loved. I'm originally from Margaret River, which is Wadandi country, and I got interested in women's health and child health, as Jo mentioned. And in the room with me today is Jo, who's our clinical health nurse, and then as well Jen, who's one of our policy officers here.
So we're all going to just have a yarn today about LARCs, which is exciting.
As well, feel free to jump in at any time with any questions you have about LARCs, and if anything I'm saying doesn't make sense. So today we're going to be talking about long-acting reversible contraceptives. So specifically the Depo-Provera, the contraceptive implant, and the Intrauterine Devices. Can you move there?
Yeah, I was going to say.
But briefly, we'll start on the types of contraceptives that there are. So there's a lot of types of contraceptives, and LARCs are just one type. So you've got your barrier, which are your condoms, external and internal, and your diaphragms. What's really great about barriers is they also protect against STIs, which a lot of these other ones don't. So short-acting hormonal is your pill, mini pill, vaginal ring. The LARCs, which we're talking about today, are your long-acting reversible contraceptives. And there's other methods such as the pull-out or abstinence or sterilisation, like getting your tubes tied or your vasectomy, hysterectomy. Emergency contraceptives like the morning after pill, copper IUD, and then all along the way you can also terminate your pregnancy, medical or surgical. So contraceptives, we're talking about the idea of preventing pregnancy. All right, so LARCs specifically are our long-acting reversible contraceptives. They're really awesome because they're a fit and forget method. So you just deal with your contraceptive once every 5 years, 10 years, something like that. And then you're preventing pregnancy in that way. They need to be put in by trained health professionals, but they are also the most effective contraceptive for preventing pregnancy. So greater than 98% effective for all of the LARCs. And they usually refer to your contraceptive implant, which goes in the arm, or your intrauterine device, which goes in the uterus. Making sense so far?
Excellent. I have a question about when you say trained health professionals, what kind of training does the health professional need to have?
So we will be addressing that in later slides.
Fantastic.
But you usually need specific training, so you need to be certified in that thing.
Oh, good. Excellent.
So, as I mentioned at the start, I did say we're going to talk about the Depo-Provera as well. This one isn't technically a long-acting reversible contraceptive, more of a medium-acting reversible contraceptive, but it's longer than your other short form, which is like the daily pill or the monthly ring. So your Depo-Provera is a contraceptive injection, usually just called the Depo, and it can go in your arm or in the buttocks. 12 weekly injections every 3 months by a health professional. And the way it works is it releases progesterone to prevent ovulation. 94% effective. So that's fairly effective for our contraceptive methods. And you do kind of start with a regular, prolonged or frequent bleeding for about a year. And then after that year, after you've got that sort of loading dose, you don't bleed. Like 70% of people don't have regular bleeds anymore. The only problem with this is there can be a delay with that return to fertility. So you'll be less fertile for like a year to 18 months after coming off the pill, off the Depo. But a really good thing about this for your practice is it doesn't require specialised training. So you can have anyone who's trained in injections and usually administers injections can administer the Depo-Provera. I'm sure there are courses out there to get some more education on that so that you can counsel your patients effectively, but you don't need to be specially certified. That's really good.
I'm trying to remember because I'm thinking I've done Depo-Provera many times and I think it's subcut, isn't it? It's not IM.
There's
Oh,
two.
there's two types.
Yeah, there's an IM and a subcut.
I think the only one I've ever done was a subcut one,
That's cool.
which is really interesting because it's unlike other sort of injections I've done before. I thought it would be a really thick fluid, but it's actually not that thick. It's real thin.
Yeah, I haven't heard, so I don't have much experience with the depot myself, but I haven't heard anything like any of the complaints similar to like the bicillin injections. So it seems to be a more tolerable injection.
Excellent. I didn't know about the 12 to 18 months, so that's quite interesting.
Yeah. And so is that the norm, or are there, I mean, obviously there are, so are the ones that take less time or more time the outliers? And that is sort of the
Yeah.
standard.
So that's
Okay,
your
12
standard.
months.
Yeah, it's a long time.
Hmm.
So that's why I guess as well, other ones we're going to be talking about, why they're reversible,
Yes,
is they're more immediately reversible. It only
Yes.
takes like one cycle or immediately
yeah, okay.
you are returning to a normal fertility.
Yeah.
So
Interesting.
the depot has
that
that
is interesting.
delayed return.
Mm.
So it makes it hard when situations change for yourself and you're like, oh, I want to get pregnant now, but it could take longer than you're expecting.
Is there a scenario, a situation? What would happen if, say, it takes longer than the 18 months? Is there any kind of intervention that can happen? Like,
Yeah, so if it takes longer than the 18 months, it's probably not caused by the depot. You're probably having other fertility issues.
okay.
That would be a whole other topic in
And then you have
itself.
to refer to
Yeah.
fertility
Yeah, man,
specialists
I
or
know,
some
if you're
sort.
thinking it's, yeah.
Sure.
Yeah.
Okay.
But yeah, it's hard because then usually fertility specialists, they wait another year because you have to be having regular sex for a year for it to be deemed like, oh, maybe you've got fertility issues.
Yeah.
So that could put off your sort of family planning by another year to 2 years. But anyway, there will be a future bites just on the depot, which I won't be delivering, someone else is delivering. So there'll be more of a deep dive into this and I'll have a lot more knowledge than I do.
Fantastic.
A depot dive.
Depot dive. Okay, so now we're getting on to like our specific LARCs, our actual long-acting reversible contraceptives. The first one's the implant. So this is your rod or implant-on. You might have heard it by other names, but it usually goes in the arm just there as it's shown on the picture. It's a flexible little rod that's inserted to the arm. It's not very scary to look at for a patient. However, they might be a bit put off by the injection kit you get it for, if that's what they're shown, because that looks scary. So the process for a patient to actually get the rod is it's prescribed, it can be prescribed by, I think it's a nurse practitioner or doctor and perhaps midwife, but I'd have to check. And they go pick it up from the pharmacy, bring it back to the clinic, and then the clinic can insert it if they're trained. It's 99.9% effective, so it's really great for preventing pregnancy. As I said at the start though, you still do need that barrier method to prevent STIs. So you're still going to use condoms when you're having sex. It releases progesterone, same as the depot, to prevent ovulation, but it's a slightly different formulation. So it prevents ovulating, thickens your cervical mucus, and thins your endometrium, which is like your lining of your uterus. So it prevents pregnancy in 3 ways. It lasts for 3 years, but it can be removed earlier. And unlike that depot, you won't have that delay in return to fertility. So you should be able to be immediately fertile again once you remove that. If it's inserted within the first 5 days of your cycle, so from the onset of your period, it's immediately effective. Otherwise, you have to wait 7 days for it to be effective form of contraception. And there's in terms of like patient tolerability, it's seen that like 1/5 of patients will have prolonged and really not great bleeds. 1/5 of people don't bleed at all. And then 3/5 of people have irregular or infrequent, more spotting type bleeding. So for some people, it's a really awesome method if they're looking to reduce their periods and want that sort of peace of mind. But you need to think of that 1/5 that will have issues with the implant. Yeah.
Is there anything on like how well tolerated the actual rod is in the arm?
Easy.
Yeah.
You barely know, well, from personal experience, I've had it before.
Yeah.
You barely notice it. It's something that you can play with a little bit, which can have some issues if you're constantly playing with it. You might release more hormone than it's actually meant to. It might not last as effectively as it should. But you have to be really playing with it a lot for it to actually reduce that cover that you've got.
I like that.
Any side effects?
Side effects. So yes, thanks for asking. Since this is a global acting thing, you're going to have that progesterone effect on your whole body. So you can still have, I guess, the hormonal side effects. You might have some weight gain, some bloating, and there's some other risks involved. I'm not sure if I mentioned it. No, don't mention it on the next slide. But yeah, it's global acting. So you will have a side effect on your whole body.
Okay.
And like boob swelling, boob pain,
Okay.
breast tenderness. So yeah, it can be those side effects.
Okay.
But the main sort of side effect that people complain about is those 1/5 that have prolonged bleeding. What is great though is while it does last for 3 years, if someone's having an issue with it, no worries, take it out and swap for something new.
Yeah.
You're not locked in.
Fantastic.
Yeah.
Anyone else on the floor have any questions? Are you happy so far? Yeah, awesome. That's great.
Easy. Well, our next thing is our intrauterine devices. So this is what kind of the rest of this presentation's on. These intrauterine devices can come in 2 main sort of forms. You have your hormonal or your copper. It's a flexible device that's inserted into the uterus. So this needs to be done via procedure. I forgot to mention, obviously your implant done under local anaesthetic, but can usually be done in a GP clinic. This intrauterine device can also be done in a GP clinic, but it'll be the patient kind of needs to take some ibuprofen. I've had it all before, like an hour before, and then you'll insert it. But this one you really do want that training in, like some really good
Is there
training.
an anaesthetic spray, I feel, is there? Or is it
Yes.
a spray they use?
There is an anaesthetic spray, there's an anaesthetic gel. It's very variable on the person on how much it hurts them. Some people don't notice at all. Like I've watched people get it who haven't even noticed. They're like, oh, is it done? And then other people find it excruciatingly painful. So
I have been told as a woman who has had 2 children, but both of them have been by cesarean, because my cervix never opened, that it would be very challenging, and so that they would put me, I could do a day procedure in a hospital.
you're so lucky.
I'm like, yes.
Yeah. So yeah, that option is also there. So you can do it as a day procedure, but you're going to learn some things about options for you today. So the hormonal one releases progesterone locally into your uterine system. So as I mentioned with the implant, that released progesterone globally into your body, and this is locally on the uterine system. So there's less side effects than the implant usually, but it's got specific side effects to that. The copper is spermotoxic, so it reduces sperm motility and it also has some effects on the lining of the uterus. And that's how that one prevents pregnancy. What's cool about these IUDs is they last for 5 to 10 years, depending on which type you get. But as well, they can be removed earlier and have that immediate return to normal fertility levels. So you put something in, put it in, and then you can forget about pregnancy for 5 years and not have to worry about it. And then you just do that procedure again. So while that can be a painful procedure, some women and people with uteruses find that by just having to suffer that once every 5 years, that's something that they can accept. They're also 98% to 99.5, greater than 99.5% effective, depending on the type. So that's awesome cover for your pregnancy worries. And this can be prescribed by doctors, nurse practitioners, or midwives. And as well, as I said before, inserted by those who are trained. But it's nurse practitioners and doctors that can access that training.
Interesting.
So the side effects you need to know, as I mentioned, that insertion can be quite painful, but depends on the person completely. It's so variable. Some people can get it done at a GA, you can get it done with just their local anaesthetic. Depends on what your centre offers and what hospitals around you offer as well. You get irregular bleeding might happen for the first few months as your body kind of gets used to this. And you need a follow-up pelvic exam 4 to 12 weeks after insertion, just to make sure that it's been inserted correctly and it's not going to be expelled, because your uterus can kind of just chuck it back out if it doesn't agree with it. There's only a 2% chance of that happening, and it's a less than 2% chance depending on which one you do. As we've mentioned with all of these, they don't protect against STIs, they just protect against pregnancy. So that condom is still needed. Any questions about broadly IUDs this time? No.
The expelling thing is quite concerning, which is interesting. 2% is quite, it's still something, you know?
Yeah, still something. And so that's, 2 in every 100 people might have it expelled, but
So,
it is something that you notice.
Yeah, of course. You'll feel it coming out. Like,
Yeah.
Okay, cool.
Or you'll notice it in your underwear or something like that.
Oh.
You'll be aware.
Is it routine to have ultrasounds done after, or?
No, you just need that pelvic exam because it's just got 2 little strings that poke out the cervix. So when you get, it's called the speculum exam, your doctor or nurse or whoever's doing that check can see the little strings sitting there and can check via a pelvic exam if it's sitting in the right spot.
Yeah, okay.
So your hormonal IUDs are the kyleena and the Marina, the main ones we use in Australia. Kyleena is new on board and has only been around for the last few years. But it's not to say that it's like something to worry about. It's a really awesome product, just raising awareness of it. So these alter the lining, the endometrium of your uterus. That prevents, if a fertilization happens, it's not going to be able to attach to the uterine wall and grow, so it's not going to be viable. It also thickens your cervical mucus, so reduces sperm swimming up through, and it can inhibit ovulation, so you're unlikely to have egg release occurring. As well with these, especially the Marina, they can reduce your bleeding, so you're not getting those periods as much or as heavy. So they're you often get irregular bleeding for 3 to 5 months as your body gets used to it. And then you'll have really light periods or you just don't bleed, which is, I'm sure any person on here can empathise. Periods suck. You don't really want to be having them. Nice to be able to skip that. These as well, the hormonals last for 5 years, so that's your fit and forget. If it's inserted during the first 7 days of your cycle, so the day 1 to 7, those first few days of your period, they're immediately effective. Otherwise, you need to wait 7 days to have that peace of mind that's definitely working. And as we mentioned before, it needs to be inserted by a trained health professional. You can get training via SHQ or ACRM also offers this sort of training. What's ACRM stand for? Rural medicine.
Rural medicine, yeah. Oh, yeah. Okay.
It's like RAC GP for rural and remote. So that's a GP course. But also other professional bodies offer this as well. SHQ offers, if you have a large amount of people who want training, they occasionally offer to come to your practice and do it there.
Nice.
So that could be something to look into.
Fantastic.
The kyleena is that new product we have on board. I spelled it wrong there. It's got 2 E's in it. Don't worry about that. So it's progesterone based and it's 19.5 milligrams. So it's a low dose of that progesterone. It lasts for 5 years, just like the Marina, and it's 98% effective at preventing pregnancy. And that's if it's used alone. As we've said with all of these, you should use it with a condom as well. So with both those covers, super unlikely that you'll get pregnant on this kyleena. It's so small as well. It's a 28 millimeter by 30 millimeter. So 2.8 centimeters times 3 centimeters. So it's small. Good for nulliparous, so women who have never had a birth before, or as Jen's mentioned, have only had cesareans, or perimenopausal women, because it's that lower dose of hormonals. So for those women, it could act when they're around those menopause years, could act as like a hormonal control for them as well. So that's really useful. Yeah, that's your kyleena. Has anyone at the services been using kyleenas at their service? Or heard of them before?
I've heard of them, but we don't do any of that stuff from here. But I know that the hospital do discuss. They talk about kyleenas with their women after they've had birth. There's an option for them.
Yeah, so as well, all these IUDs are safe when you're breastfeeding, and the implant as well. So while the IUDs, you wait a few months, I think it's 3 months after the birth's occurred. so that they can have like that healing and let that area die down a bit. You can have that inserted and it's safe while you're breastfeeding, which is really awesome because like your combined oral contraceptive pill isn't safe during that time.
Fantastic.
So if we move on to the Marina, this is kind of the classical one you think of when you think of an IUD. It's progesterone based as well, and it's a higher dose, so that's 52 milligrams compared to the 17. So higher dose. As well, lasts for 5 years. And because it's that higher dose, it's more effective at preventing pregnancy. 99.5% has occurred, or greater than 99.5% compared to the 98% that kyleena is. This one's slightly bigger, so it's 32 millimeters by 32 millimeters rather than 28 by 30. So it's a little bit bigger. And because of this, you get a higher risk of the side effects. So some of the side effects of these is ovarian cysts, which are benign, but they can be really painful and treated with NSAIDs. So with your normal ovulation, some people can get ovulation pain, which is called middle schmerz.
Little schmerz?
Yeah,
Okay.
which means middle pain.
Okay.
In German. And when you ovulate, it's actually quite similar to a little cyst bursting on your ovaries, and then your egg travels up through your system. But with these IUDs, you don't get those ovulatory cycles because it prevents ovulation, but you still can get cysts bursting. And then that fluid can irritate your peritoneum. So you can get quite painful cysts. It's not super common, but it is a side effect you need to be aware of. What's really awesome though, and how you can differentiate it from, oh my gosh, is my patient having appendicitis? If you just take some NSAIDs, so some ibuprofen or something like that, that pain's completely gone. So just something to keep in mind for your patients. Is there anything else I wanted to say about Marina? So if you don't have any questions about the hormonal IUDs, the kyleena and the Marina?
Is that the only side effect difference sort of between the kyleena and the Marina, like because of that difference in progesterone?
Yeah, so the risk's still there with kyleena. All the Marina side effects, the risk is there with kyleena.
Yeah.
And I haven't delved into all the side effects that there are because everything's got has side effects. But that's just one that I like to keep in mind. But yeah, it's a higher risk because of the Marina's higher dose. What I forgot to mention about the Marina, something really cool about it is the Marina is also on the PBS for treating heavy bleeding, so like really heavy periods.
Good.
So because it reduces your bleeds, you can prescribe this to your patients, not if they want contraceptive, but also if they just want that to reduce how heavy their periods are and they're getting so exhausted and tired and painful from it. This is a good treatment for that. Maybe helpful there too.
Interesting. Fantastic.
Any questions?
No, good.
So your other IUD is the copper. This one isn't on the PBS, so I don't know as much about it since mine's merely due to exposure. But it's toxic to sperm and it prevents fertilization by the same thing with the uterus lining, thinning it so that your zygote can't implant. Oops. So prevents implantation of that little fetus, and it's also spermatoxic, so it reduces sperm motility up, so sperm are less likely to swim up. What's really cool about the copper is that it's a non-hormonal option. So if you've got women who want something to reduce their chance of getting pregnant but don't want to mess with their hormones, this is something you can suggest. What's also really cool about it is there's a few different options and they last from 5 to 10 years. So the fit and forget could be even bigger where someone just puts it in for 10 years. Doesn't have to think about it. It's 99.2% effective at preventing pregnancy, but this one has the side effect that it can increase your menstrual bleeding and your pelvic pain. So it's not something you'd recommend. It's not something you'd recommend for patients who are already having heavy bleeding. That's like a risk that can happen there. The benefits though is that it's immediately effective, and it's so immediately effective that you can also use it as an emergency contraception. So same as like the morning after pill, you can put this in and then they've got protection for 10 years and also they've prevented that pregnancy from occurring. I think it's only 5 days that it needs to be put in by. So if you have, if they have the sex on that day, they've got 5 days to get this implanted to prevent that pregnancy from occurring.
As opposed to the morning after pill, which is what, 72 hours, right?
2 to 3 days. Yeah.
So that's good if there's like, if they come in for a late presentation.
Yeah. And as well, it's really awesome because it gives that 10-year option or the 5-year option.
Yeah.
So
I've definitely heard of it being used as a means
that.
of contraception. I think that's the main use for it now, just because of its not being on the PBS, it's not really feasible.
I've heard as well with the people who are like, haven't responded well to hormonal contraceptives, this is something that I consider. So yeah, it's not on the PBS, but only $100 for 5 to 10 years. $100 over 5 years is cheaper than the pill. So
Very true.
yeah.
Excellent.
And then here's just a bit of a review because that was so much information. So if you're to compare them all against each other, I like to think of it in this way when I'm thinking of the patient in front of me. So the kyleena, Marina and contraceptive implant are all on the PBS. That's the mechanism of action there. The duration, 5 years, 5 to 10 years, or 2 years. They're either progesterone based or not hormonal at all. Efficacy, as we said at the start, is all above 98%, but ranging from 98 to greater than 99.5, 99.2, and 99.9. The effects it has on your menstrual bleeding. So as we mentioned, that Marina does significantly reduce that bleeding, so it can be prescribed for that. Whereas the copper can increase the bleeding. That implant has that variable effect on people, and kyleena has just a light reduce. And then your area of effect. That's when you think about the side effects. Is it local on the uterus, like all the IUDs, or is it global on the body, like the implant? And then just some other notes for yourself. So kyleena is great because it's smaller, for that nulliparous or premenopausal. Marina is for heavy bleeding and can be used for some other gynae issues as well. Copper is your emergency contraceptive. And your implant, the procedure can be easier for the patient because it's not inserted into their uterus, so it can often feel like less scary. And it can be done immediately postpartum. So,
does kyleena ever get used for heavy bleeding as well, or no, because of that low progesterone?
I would say at this stage the studies haven't come out on that.
Yeah.
But the low progesterone,
it's fairly new.
It's fairly new. So it only got on the PBS. It was within the last 5 years. So yeah, as well, it reduces your menstrual bleeding, but at this point with that low progesterone, I don't know if it significantly reduces it.
I guess I wonder about that, because if you wanted something like that and you didn't want to mess
with your hormones too much.
Like if you didn't want to like go over the top messing with hormones, so I guess less bleeding would be better than really heavy bleeding. So you might go, oh, okay. And knowing that it's smaller perhaps, and so like giving that a go and then being able to explore it and see, oh, well, how does this affect my flow? And is it lighter so it's more manageable?
Yeah, so that's how I would personally do it if I was the treating clinician.
Yeah.
I'd be like, hey, kyleena, if you haven't tried out IUDs before, it's probably a good, easy starter one.
Yeah.
And just see if it's something that suits you.
Yes.
But in saying that, you need to look specifically at the side effects and your patient and look at all those things together as well. Yeah. So I'll be sending out these slides later as well, and this will be reviewed, so you'll recorded, so you'll have access to that. But I just wanted to make a quick note on training. So can you be a LARCer? To be trained to insert IUDs or the implant, you do need that specific training from either SHQ or ACRIM or other professional bodies. At this stage, as far as I could find out, you have to be a doctor or an RN to do these procedures. But anyone at the practice can promote the clients and colleagues to consider LARCs as an option and promote the community and professional awareness about these contraceptives, because they're often not thought of as a first point of call for especially younger people. And it can be a lot more manageable than the pill, which is usually everyone's like starter contraceptive.
Yeah. Yes, and having to remember to take it and
every day within 2 hours. I don't think my pill was ever effective. So it can be a lot more manageable for your patients. Yeah, do we have any questions? And fun fact, they're all safe when you're breastfeeding.
That was awesome. Thank you.
No worries.
I've got just one quick question. Sorry if that's all right. It's actually about the depot, funnily enough, not any of the other ones. But I was just wondering, is there actually still much of an uptake with those? I feel like we're sort of trending away from that now. And then when you sort of read the disadvantages that come with the depots, are they even sort of promoted by services when you've got all these other options?
I would say, like in my experience, they are less promoted than any of the other options. But it depends on what your patient is going to find the most useful. And there will be that deeper dive coming out from someone who's a lot more knowledgeable about depots than myself. So I'd recommend tuning into that. But yeah, I understand what you're meaning there, Claire. They're not, the side effects are quite big. It's a 3-monthly injection that you need to remember. And you could just get the implant and have kind of the same thing. But yeah, great point.
But there's obviously still a group of people that take it up, do they? There's still
yeah, there's still a group of people, especially I found from what I've seen, it's those people who are already getting regular injections, like the psychological, like quinolone or those sort of things. So yeah, it's your psychiatric patients who are already getting a 3-monthly injection. So usually the service kind of tease it up with that.
Yeah, that makes sense.
Or people who have quirky things probably about like something being in there.
Exactly, having something in there is a great thing.
We have to also think there's a cohort of people that are subject to reproductive violence, and that's because of like having the progesterone implant sort of in their arm.
It is something you can find and see that they're wearing it.
People have been known to partners have been known to rip them out. So
yeah, so that would be.
So that it provides that kind of longer acting contraceptive, but without any signs that it's there.
Yeah.
I don't want to mention it because I was thinking about it because it's something I've been reading with the WHO lately. They've been really advocating for this practice to stop.
Yeah.
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 There you go. Any other questions?
I do have an interesting note on a similar-ish but not the same topic.
Yeah, go for it.
One of the complaints that you sometimes do get with the IUDs, depending on how long the person who inserts it cuts the strings, is sometimes if they're having insertive sex, so penis vagina sex or something like that, the partner can feel the strings when they're having sex.
Okay.
So it can be either an adjustment period or it might not work for certain relationships if that's damaging the sex life.
Interesting.
But,
again, that's so person-centered.
So person and relationship centered as to whether that actually drives an issue. Yeah. If there's any other questions, feel free to fire them at me. But otherwise, thanks for attending, guys. Sorry.
Before you go, actually, I kind of want to know from you all, like what. Excuse me. What are you all like in terms of like what are your Aboriginal clients normally accessing? Well, what is their, I guess, LARC of choice? Or what sort of...
Or just contraceptive of choice. Do many people actually have to take LARCs?
I'd like to know from all of you.
Candice, do you have any thoughts on our population here in the Goldfields? I know that they do promote rods a lot, especially in our remote Aboriginal communities. I think they're more accessible, and so I know they're given out a lot, but I don't really know if that they're the most used or not. But do Candice and Brenda have any other comments on that?
Hello.
Okay.
I was going to say the same as Claire. I think the most common one here used is the implant.
Yeah, I'd say as well, I actually did some placements at the Wax Hospital in Kalgoorlie. And so I would say from what I saw there, the GP centres were doing a lot of the implantons, but if they were coming into the hospital, it was to do the IUDs. So, yeah.
And one last question, I guess, is it well tolerated with those clients, or have you had any situations that really stood out where it wasn't as well tolerated?
I don't know if you've got anything to add, Brenda or Candice, but I think the only thing that I've heard pop up is can be a reluctance because, as you say, the rods can be felt. That there can be a reluctance for different reasons for people not wanting them, and for women, for girls not wanting them, and because they're not just felt by themselves but felt by partners and boys as well. So, but yeah, then I don't know, Candice, if you've got anything to add to that, but that's the only thing that I sort of have heard come up.
Yeah, no, same as Claire. Some of the times when we go into the schools and stuff and talk to the young girls, they'll say, oh, they heard, their friend had this, and kind of like the myths about it, weight gain, more bleeding or less bleeding, or that it can make you like infertile. So they'll be just telling us about some of the things that they've heard from other people that have had it, and then that kind of makes them not want to get it.
It is really hard with a lot of these contraceptives. People obviously they hear most of it about their friends, and people usually only share their horror stories. No one shares their great news story. Because if it's great news, it means it's working and you don't have to think about it.
Yeah.
So it is really good that you guys are doing those education in schools to spread the word a bit more. But I know myself, I didn't learn about this till I went to uni, and I was like, oh, I wish I had access to all this knowledge when I was younger.
I was going to say, same, like I went to, I guess, religious schools especially, they do not like any kind of external training provided in this space. So I didn't learn about it till uni. So yeah, there you go.
Yeah. Anyway, this session's obviously been recorded and will be uploaded. I can also send the slides around if you guys would appreciate that. But I'll let Dee do that once she gets back.
Cool. If you have any questions about this sort of stuff, contact Summer directly, because they're a wealth of knowledge and they'll answer anything. I'm just putting you on the spot. You are a wealth of knowledge and you will answer any question that comes across, or you'll find the right person for it. So it's summer.porter@aqua.org, or you can just contact our generic email, public.health@aqua.org. Either or is fine. And yeah, it's great.
Yeah. Feel free to hit me up if you have any questions about that. But thanks so much for coming today, guys.
If you LARC what you're hearing.
If you LARC it.
Oh my God, Stan. No, you're not saying that.
I love
We
that.
did.
Yeah,
We did.
Okay.
All right, see you all. Have a
Bye,
nice
Thanks very
time.
much, guys.
Thank you.
See ya. Oh, thanks for the claps. Cheers. Bye, everyone.